Okay, so our final conversation is actually probably something you will get the most questions about in your athletic training career from the general population of when do I use cold and when do I use heat? And how do we make that transition? So just a quick little review of what cold does and what heat does. So effective depths, okay, if we're getting deep, we can get deeper to that 5 centimeters, but otherwise we're only talking 1 to 2. Cold gets to about 5. Um, the duration of the treatment, go back here, the duration of the effects is usually hours. This begins to dissipate relatively quickly once we remove the modality. Maybe in the deeper treatment, we can get that increased temp for about 30 minutes, but that doesn't mean that it's physiologically effective for that whole 30 minutes. Blood flow decreases with vasoconstriction, increases with vasodilation. We get the reverse of cell metabolism, the reverse of oxygen consumption, the reverse of cell waste, the reverse of viscosity increases or decreases. Capillary permeability, also the opposite. So yeah, this arrow should be up. That's a typo in your book. The viscosity increases with cold. Inflammation are opposites of each other. Pain, both decrease pain. Okay, so again, when we start thinking if that's the only indication for what we're doing, we can start to think about which one is beneficial for our patient and which one the patient wants more of. Muscle spasm, both were reduced, but for kind of different reasons. Both definitely because of pain. This one's more because of muscle spindle sensitivity reduction. This is more because of reducing the ischemia. It will decrease muscle contractions because of that nerve conduction velocity, while heat will actually increase that. So we get an increased nerve conduction velocity and that decrease in the fluid viscosity. Okay, so heat versus cold. What, when, and why? So in immediate care, cold is going to limit secondary injury, thus going to also decrease muscle spasms and pain. Okay, heat is 100% contraindicated during the immediate care. Why? Well, should be obvious, right? If we increase the cell metabolism, we're going to promote secondary metabolic injury, and we don't want that in the immediate care. We don't want to add injury to our already injured tissue. So the pain reduction trumps any sort of tissue stiffness or things like that. The idea that we are trying to reduce secondary cell death automatically means we are going to use cold for immediate care, 100%, all the time. Now, when we start getting into subacute care, we got to start thinking about what is happening to the body and what we need to have happen. So cold is going to decrease circulation. It's going to decrease metabolism, going to decrease inflammation. It's also going to increase muscle or tissue stiffness. Are those problems for our current patient? That's what you need to ask yourself. So lots of these effects are actually detrimental, but we do need the decreased pain and the decreased muscle spasm that cold can do. So the best kind of things that we can do is to exercise. Okay, so if we can facilitate exercise, we get the tissue, the circulation that it needs, we get the metabolism that it needs, and we get them functioning, which we know is important to decrease a lot of our other signs and symptoms, decreasing spasm, decreasing the arthrogenic inhibition, all of that central control, things like that, the neural inhibition. So the main benefit that we can do is to exercise, and whatever is going to facilitate that exercise the best. Okay, that's what we want to do. So if pain is preventing active exercise, cold is usually our best because we can induce pain relief and enable that active exercise. Heat is actually not as effective in facilitating exercise after that acute injury. It actually sends someone back into kind of the pain spasm cycle. Now, it can facilitate exercise when stiffness or soreness is what is kind of limiting activity, but that's going to be much later in the inflammatory response cycle. So cryokinetics can always begin sooner than thermotherapy and exercise. So if the goal is to facilitate exercise in that subacute stage, cold is going to be our best bet. And then as they advance later on, we can potentially start to be looking at heat. In the late subacute, so the 10 to 15 days following acute injury, this is when we can really start to treat the soreness with heat. And we can also treat muscle spasms with heat, but again, muscle spasms actually respond better to cold. It's just usually the individual who prefers the heat. Sprains that are sore, but the exercise is fine, that's when we can start to maybe think about heating pre activity, just to kind of eliminate some of that stiffness, and then potentially using some cold post to help eliminate any pain that was maybe established with the activity. But again, that's kind of personal preference. Chronic injuries, secondary metabolic injury is no longer a concern in a chronic situation. What's happening is that that person is usually probably stuck in that low grade inflammatory response where nothing's really moving forward, but we're kind of stuck with the inflammatory mediators and so on. So actually sometimes heat, which is pro-inflammation, can help advance and push through that chronic inflammation to try to restart and reignite the inflammatory response cycle, so we start to actually get healing. However, if it's an overactive inflammatory response, if that's what's causing this chronic pain, then we'd want to stick with cold application. But in this stages, the evidence really is kind of all mixed and all over the place. Again, soreness is going to respond better to heat than to cold. Some of this will end up being kind of a personal preference of what is facilitating the patient the best, and that's what we would need to think about. So the question then becomes, when do I know to switch from cold to heat? So these are some questions to kind of ask yourself, okay? We want to make sure that there's normal skin temperature. So does the body area feel warm to the touch, okay? As the number of yeses increase, that's more of an indication that we should be sticking with cold. So again, does the skin feel warm to the touch? If that's a yes, we should stick with cold. Okay, if it's feeling more normal, then we can start thinking maybe it's transition time. Is the injured area still sensitive to light or moderate touch? So again, is it still fairly painful, especially light and moderate? That would be a sign of inflammation, right? So that would be, if the answer is yes to that, that indicates that we're probably still in that inflammatory response and we'd want cold. Does the amount of swelling continue to increase over time? So is there still fluctuation? Is there differences from morning to night? If they go in a gravity-dependent position, does it increase swelling? If the answer is yes to that, then it's probably more cold. If the swelling is looking controlled, so there's still swelling present, but it's old edema, it's not changing, it's left over, then heat might actually be more effective. Does the swelling increase during activity or joint motion? That again has to do with that fluctuation. Does pain limit joints range of motion? So again, pain limiting exercise, that's an indication for cold. Would you consider the acute inflammatory process to still be active? So again, are we thinking those 5 signs of inflammation are still really present and still active and still changing? Does the patient continue to display improvement with the use of cold modalities? So that goes with kind of the question over on the left too. Is there no further progress with cryotherapy? So if the person is still progressing with cold, keep using cold. If they're kind of plateauing, then maybe it's the chance to try a little heat and see if we can push some things along. As long as, again, we're not seeing really active signs of the 5 signs of inflammation anymore.